Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Today's presenter is Dr. Jennifer Chan. Dr. Chan is a thoracic surgeon.
All right. I am Dr. Chan. Welcome everybody to this very informal conversation, okay? Let's just make this very clear. It's going to be informal. So let's get started. So let's talk about GERD. Before we talk, some of the objectives I want you to come away from this afternoon are, again, this is just an introduction to GERD. I want you to the plan is to come away with a better understanding of what GERD is and what it is not. What are the risk factors for GERD and its causes, as well as some of the management of GERD. So let's start off by, what is GERD? GERD technically stands for Gastroesophageal Reflux Disease. It's also known as heartburn, reflux, indigestion. And by definition, it's a condition in which the stomach contents reflux back into your esophagus and cause symptoms and or complications. And what does it feel like? This is what I'm told it feels like. Basically, your stomach, your chest, it feels like you're on fire. And how common is GERD? Consistent numbers show that at least 20% of the US population experience some form of GERD. It can be as high as 40% and up to 7 to 10% experience daily symptoms. What influences reflux disease? Number one is diet. Western diet, low fiber, high fat, stress, weight gain with obesity, as well as pregnancy. I do tell my female patients if they've had a pregnancy that they can usually blame their children for their symptoms. It affects all ages and genders. We actually have a number of infants who are born with GERD, and there's no gender disparity between male and female. It affects everyone equally. And we see it more and more with increasing age. So what are the symptoms? Well, we break down symptoms into what's called typical symptoms, or the common symptoms, and these are heartburn, regurgitation, where acid comes back into either your mouth or the back of your throat or your chest, trouble swallowing, what we call dysphagia, bloating, belching, nausea, and vomiting. And these are all just very common symptoms that we see. Some of the less common symptoms that we see include chest pain. People have described it as like having a heart attack, chronic cough or wheezing, asthma, allergies, similar symptoms to that, and hoarseness and voice changes. So why does GERD happen? Well, there's two parts. On the left, you see what we hope is a normal stomach and esophagus. The esophagus is this tube that brings food from your mouth, somewhere up here, down into your stomach. There's your stomach. There's a sphincter, or what we call the lower esophageal sphincter between the esophagus and the stomach. When you eat food passes down. Somewhere along the way, your brain says, okay, food's coming down, I'm gonna open up. Open up, let the food come in. As soon as the food's in there, it closes down, and the stomach does its thing. Well, reflux happens when the sphincter doesn't work so well. And there are a number of reasons why the sphincter doesn't work so well. The other caveat is the diaphragm. So the diaphragm is just the muscle that separates the chest up here from the abdomen down here, or the belly. And it's a muscle. There's an opening between the two. What happens is that when you have a weak diaphragm, it's either widened for a various number of reasons. Part of the stomach herniates up. This is what we call a hiatal hernia, okay? Part of the stomach enters into the chest cavity. Well, why is this important? Well, we talked about the sphincter right here. This sphincter doesn't work well in the chest. There's a very complicated set of mechanisms that allow your lungs to move, allow you to breathe, and allow you to your heart to beat, and it's a different pressure than what you have in your belly. So when the sphincter ends up in the chest, it doesn't work so well. So I have a few pictures of real life patients who have been diagnosed with hiatal hernias and reflux disease. And hopefully no one's squeamish here, but they are some pictures from the operating room. So this is a patient with a small sliding hiatal hernia. The esophagus comes down, the diaphragm is down here. This is part of the stomach that comes up into the chest. And you can see some of what we call the stomach folds between. In the operating room, it looks pretty normal. Here's the liver, here's some of the fat, here's the stomach. And you can see there's an opening around here where the diaphragm is. That's the opening that you normally have. When we take a better look of this patient, we pull some of the stomach down. She had a very small hernia. This little part kept coming up and down. It's a much bigger hole than you expect. Slightly larger hiatal hernia. Here's the esophagus. It's a little wider than normal. Here is part of the stomach, and here's the diaphragm between here and here. So this much of the stomach was in the chest. What does that look like? Again, here's the stomach, here's the hole. Up in here is, I think, the lung. So you see this big hole that allows the stomach to go into the chest. And yet another, I like pictures, so don't mind me. Another hernia, again, another esophagus. Here's part of the stomach, and we know this because the way the stomach looks with contrast. It has these folds. The diaphragm's way down here. And again, it doesn't really matter what the size of the hole is. The stomach goes up, okay? And then a very large hiatal hernia. This patient actually had more shortness of breath. So what are we looking at? We are looking at the esophagus and the stomach turned upside down and completely in the chest. She couldn't eat too much for obvious reasons. And when we look in the operating room, here's what is going up into the chest. This is actually not really stomach, this is actually colon. So her entire stomach and colon was up in the chest. As a caveat, I have to say that stomach acid is not the enemy. There's a role for stomach acid. Stomach acid has a very important role for digestion, helps break down your food. It actually has a role in maintaining your healthy gut flora for later on in the intestine, small intestine, and colon. However, there is no role for acid in the esophagus or the airway, which I will talk about. And why should we care? Well, GERD, or reflux disease, long-term complications of GERD can lead to strictures. It also leads to what we call interstitial lung disease. It's just where you aspirate or enough stomach acid enters into your airway, and it causes permanent damage to your lungs. And one of the most common reasons for interstitial lung disease is reflux disease. And interstitial lung disease is an indication for lung transplant. So there are a number of patients out there with bad lung disease because they have bad reflux. The other thing that we talk about is Barrett's esophagus. So what is Barrett's esophagus? Barrett's esophagus is a change in the esophageal lining. So the stomach, because it produces acid, has specialized cells to help deal with it. It's almost like your stomach is coated in this armor. In your esophagus, it's a different cell type. It's like a cell type of your skin. It's a very flat cell type, and it's not used to acid exposure. So Barrett's is the actual changing of the esophagus lining to something that looks a little bit more intestinal or stomach-like. So that's what we call Barrett's. And it is considered almost a precancerous change to the esophagus. As I said before, both males and females get GERD equally, but males have a higher incidence of Barrett's and males have a higher incidence of cancer, okay? GERD can lead to cancer. And the type of cancer that we see is actually a cancer called adenocarcinoma. There are two types mainly of esophageal cancer. One is squamous cell. We used to see a lot of squamous cells cancers in smokers and drinkers and very male dominant population. And you can actually see this line, this green line, I don't know if you can see it all that well, is the incidence of squamous cell cancers, and it's on a downward trajectory. And we think that's partly due to more information about smoking and tobacco use with cancer. The other interesting thing that we've seen over the last 30, 40 years is the rise of adenocarcinoma, which we associate with reflux disease. And it's partly because we're using we know more about reflux disease, we know more about medications for reflux disease, and we'll talk more about that. All right, so winding down very, very quickly, treatment. So what can we do about treatment? There's 3 aspects of treatment. You, that's number 1. Yes, you. First thing we do is dietary modifications. There are certain foods that affect patients. Every patient is different. Caffeine, spicy foods, alcohol, citrus or tomato-based foods, and chocolate. Large meals, you tend to fill up your stomach, it tends to put more pressure on your sphincter and things come up. Another modification is not lying down right away after you eat. You wait 2 to 3 hours. I have patients who their last meal is at 6, they don't go to sleep until 9 or 10, and that's how they manage. Some of the other things that we talk about, losing weight. If you are heavy, especially in the belly area, your stomach gets pushed up. It causes that hernia. It contributes to that hernia. So if you are on the heavier side, we say if you can lose some weight, that actually will help with your symptoms. Sleeping with your head elevated, so 2 to 3 pillows at night. And not many people know, but if you sleep on your left side, it helps empty your stomach. By sleeping on your left side, you have less incidence of reflux at night. And if you can, avoid stooping or bending over. So medications, there are a host of medications that we use for reflux disease. Antacids, we're talking about your over-the-counter Tums. Those before antacids, we had H2 blockers, the Zantac, the Pepcid, the Tagamet, the acid. And finally, proton pump inhibitors, omeprazole, Prevacid, Acifix, Nexium. So what do these medications do? Well, they decrease acid production in the stomach by 2 different mechanisms. One is you have histamine receptors and proton pump cells that help produce the acid. So these medications act on those receptors to decrease acid production. So beyond medication, I will say this, the majority of patients are well controlled with both behavioral modifications and medication. So we're talking about maybe 70 to 80% of patients can manage their symptoms just with medications and dietary and lifestyle modifications. But there are some side effects to the medications, and there are some costs to the medications, depending on whether it be a generic brand or a name brand, whether insurance covers it or not. For a single once a day, 30-day supply of a PPI, whether it be a Nexium or a Protonix or one of those drugs, it can go anywhere from under $20 to as much as $400 a month. And as we know, healthcare costs adds up. Medication for reflux disease is a multi-billion-dollar industry. It is consistently one of the top 5 classes of drugs that are prescribed for the US population. It used to be one of the top 3, but unfortunately been pushed down after pain medication and blood pressure and diabetic medication. So it's still consistently one of the top 5 classes of medications prescribed. We're learning more and more about the side effects of PPI use, and I use PPI just because it's the most studied. Proton pump inhibitor use. So as I said before, you need acid to help with digestion. Acid does play a role. There are long-term effects of PPI use. These are some of the published risk factors that happen when you take this long-term high dosages, meaning twice a day, every day. We're talking anemia, we're talking pneumonia, dementia, osteoporosis, bacterial infections in the intestine, gastric polyps, which tend to be benign, but still you form polyps. There's other interactions with medications. As you get older, you tend to take a host of medications, including anticoagulants such as Plavix, Motrin, NSAIDs, and all that. There's interactions with those medications. And there also is an effect on kidney disease because the kidney helps maintain your acid-base balance in the body. So by taking PPIs, you're sort of interfering with that acid-base balance. So beyond medication. So as I said, most patients are well controlled with lifestyle, dietary, and modifications as well as medications. But there are some patients we have to consider their anatomy. Okay, so going back to our picture, if you have a hiatal hernia or a weak sphincter, you can take all the medication that you want. It will decrease the acid production, but it actually doesn't decrease the actual physical refluxing. It makes you feel better because you don't feel that acid burn, but it doesn't stop the reflux. You just don't feel it. So again, the lower esophageal sphincter here and the diaphragm play a huge role. So surgery, and I say surgery meaning, we'll talk about that. So the principles of surgery. Number one, if you have an anatomical defect, meaning you've got a hiatal hernia or there's with an enlarged diaphragm or hole, or you've got a weak sphincter. Those are the things that we address with surgery. Medication doesn't help this. There's endoscopic procedures, and we'll talk a little bit about that, and minimally invasive surgery. And that includes the fundoplication and the devices. Oh, as a caveat, I have no relationship with links other than I do links. So endoscopic approaches. One of the approaches that people have used is what we call the transoral incisionless fundoplication. Basically, it's an endoscopic procedure where they have a special scope where they suck in part of your stomach close to the sphincter and they staple it to sort of recreate a sphincter. Now this works well, but it doesn't address potential hiatal hernia. If you've got a hernia, you're still gonna have reflux. The other option is what we call the stretta procedure. Again, an endoscopic, so no surgery. You go down in with a scope through your mouth into your esophagus. They inflate a balloon around your sphincter, and they basically apply radiofrequency ablation, or they burn it. So it causes scarring. And it helps tighten the sphincter, but again, it doesn't address a potential hiatal hernia. There are some places that combine the two, but at that point, you've already had surgery. So what is surgery? And I don't know if this is showing up so well. When we talk about surgery, we're talking about laparoscopic or minimally invasive or robotic surgery. And the incisions that we typically make are usually 5 small, less than 1 centimeter port-sized holes in your belly. It can be done laparoscopically, where the surgeon's standing at bedside, or robotically, where the surgeon is at a console and there's a robot helping to perform the surgery. And I specifically chose a female surgeon performing the surgery here. So the gold standard is what we call fundoplication, or Nissen fundoplication. It wasn't actually devised that long ago. It was actually performed first in 1955. So we're talking 60 years ago-ish, by Dr., of course, Nissen. It was popularized in the 1970s. And again, at this point, we did not have laparoscopic surgery. So we're talking about a zipper incision from the bottom of your breastbone down to your belly button, okay? When laparoscopic techniques came in the early 1990s, there was a renaissance of this procedure again. There are some variations to the procedure depending on the amount of wrap, okay? So a Nissen is a 360 wrap. So if this is your stomach and your esophagus, we take this portion of your stomach, which is the top portion called the fundus, and we sort of bring it around and we sort of create a new sphincter, okay? So the Nissen is a 360 wrap. The Belzi, Thal, Door, and Toupet are variations of that, and they're less than 360. They're less than a full circle. The newest kid on the block is what we call the Lynx. It is the only FDA-approved device on the market that addresses reflux disease, and it was first approved in 2012. So what it is the titanium bracelet, if you will, magnets. It is MRI safe. And we place it around your sphincter right here. And it acts with your body. So when you eat, your esophagus will still have the commands from your brain saying, okay, it's time to open. But what it does is it helps strengthen it so that when it closes, you're not having that reflux back up. The difference between a laparoscopic Nissen and the Lynx device really is minimal. One is traditional, one has an implant. The length of stay in the hospital, the Lynx, you go home the same day. The Nissen, you stay overnight. And we're talking about the same cuts. So it's whether or not you do a Nissen versus a Lynx, it really doesn't matter. Any patient who qualifies for a Nissen should qualify for a Lynx. So what does that look like in real life? So this patient, this is after the hernia was reduced. The esophagus is circled down here with the rubber band. This is the diaphragm, there's that hole. So we close the hole, and then we bring the part of the stomach around and wrap it. And in this patient that we saw earlier with the smaller hernia, again, there's the hole. And you can't really see it all that well, but I did close this defect, tighten it a little bit, and we put a little bracelet around it. So what are the results of this? So we're comparing the Lynx device to the Nissen, which is our gold standard. There are some advantages to the Lynx device over the Nissen. One is the ability to belch and vomit. Now, you don't think it's much of an advantage, so why would you want to vomit? But if you're sick and you have an upset stomach, you want to vomit. With the Nissen, theoretically, you don't really have that ability anymore. The main thing that we're looking at is in these patients who came off their medication. About the same, so there's no difference. More recently, there was a study that was published last year that looked at 200 patients who underwent the Lynx device, large hiatal hernias, and at 9 months, 94% had complete independence from their medication. And yet, no surgery is perfect. So I had to scour the data and look through the Danes, just because they have a very nice registry of over 3,000 patients who underwent a fundoplication. That would be either a Nissen, a laparoscopic, or open technique. Partial, we don't know. That's the unfortunate part. But this shows us that from around the 10 to 15 year mark, there's a substantial increase in PPI use. They've broken this down based on, I believe, intervals of timing. So, and this is partly technique, partly technology with laparoscopic as well as robotic technology coming into play. But even with surgery, there are still some patients who require PPIs. Their symptoms are not gone completely. So the patients we discuss for surgery are the patients who, for various reasons, cannot take the medication long term. Either they don't want the cost, or they're just not doing well with medication, or they've got complications of reflux, whether it be a stricture or Barrett's or whatnot. Surgery and any of the endoscopic techniques, they're not meant for patients who occasionally have reflux, maybe take a pill once in a while. We're talking twice a day, once a day dosage of medication, and their symptoms are still not controlled. Okay? And that's it. So thank you.